Hi, this is QD Clinic, brought to you by Room Now Live. I'm Dr. Jack Cush. Today's case is entitled, Give Them an Inch, and, well, let's get into the case before we hear the rest of the story. This is a story of a 56-year-old woman who has lupus for a good time now, maybe going back almost like 18 years. I'm imagining her for a long time. Great gal, problematic lupus. Now she's doing good. You know, a few years ago she was doing bad. Her story over 18 years has been mostly good, but a lot of bad. And what do I mean by that? Her lupus has been complicated by episodes of nephritis, cerebritis, renal insufficiency, pneumonia, including PJP pneumonia. Her lupus is based on fatigue, arthritis, leukopenia, anemia, mouth ulcers, nephrotic syndrome, nephritis, polyarthritis, an ANA, a double-stranded DNA, a lymphadenopathy, scleritis, a renal biopsy showing class 4 nephritis, previously treated with prednisone, Plaquenil, methotrexate, Cellcept, Cytoxan, azathioprine, and nonsteroidals. A few years ago, she was in the hospital with both nephritis and PJP pneumonia, really was critically ill, and came back, but not without a significant impact on renal function. She now has a creatinine of almost 2 and some low-grade proteinuria, but is doing really, really well on her current medicines, which are an appropriate dose of hydroxychloroquine, 100 milligrams of azathioprine, not quite 2 milligrams per kilogram, between 1.5 and 2. She's also on blood pressure medicine and for her kidneys, and takes acetaminophen and Fosamax. So what's big or important about this case? She's doing great. She's doing wonderful, has been doing wonderful for the last 5 visits since she got out of the hospital 2.5 years ago. And that's the problem. When all is looking good, then patients can interpret that as, hey, I'm great. Maybe I don't need as much medicine. And that's the problem. What happens in this situation, not with this patient, is sometimes they go AWOL. They don't come in. They stop taking their medicine, or maybe they don't, or they take it irregularly. But when they show up, 6 months late, and telling you maybe they're taking the medicine, you're not surprised when things are out of control. This particular patient shows up on time, but she has self-adjusted her medication. Not in this house, we don't do that. So what did she do? She went off of prednisone. I think problematic, difficult lupus should always be on a little bit of prednisone. And that's just a personal preference based on something taught to me by Dr. Ziff, and when I was working at the Parkland Clinic and seeing tons of lupus patients, the ones off of prednisone were always in the hospital. The ones on prednisone were usually not in the hospital. So a little bit of prednisone, 2.5, 2 milligrams, 5 milligrams, whatever it takes. She went off it on her own. Not a good idea. She also happened to self-adjust, downward adjust her DMARD therapy. She's taking very little azathioprine. She's taking the lowest possible dose of hydroxychloroquine. Again, not in this house. So we had a little come to Jesus moment and said, can't do that. And the patient needs to understand that. And we had to go reiterate some of the big points here. And that is, who changes medicines? Only one person. And that's the guy who, or the gal, who writes the prescription. So I don't mess around with their Cardizem. I don't mess around with Xarelto. If I didn't write the prescription, I may have a strong position about it. But if I think that medicine's got to change, I have to go back to the source. Again, I remind the patient that when a doctor treats himself, we usually tell him he has a fool for a patient. And so when patients treat themselves, it's probably a worse situation. It's worse than being a fool in making medication choices. Again, when they're doing well, they want to think, I'm normal. That's the second point. You're never normal. You're never, ever going to be in remission. You got a disease like rheumatoid arthritis and lupus, you got to be teaching the point that this is something we can control. This is something we have to work out. This is something you have to own up to and accept and understand what it's like to be a good patient. And it's my job to teach you what it's like to be a good patient. Again, my job is to see you and say, hey, you're doing great. Hey, you're doing wonderful. Hey, taking the medicine's really paid off for you. But I have to leave the message, you got to stay on this medicine. If you go off of it, bad things are going to happen. So again, not being vigilant about my instructions, it's not surprising that the patient has come back and self-managed herself. Luckily, no problems at this point, but we got to get back on track. You got to do this with every patient, every visit. They listen to everything you say. If you don't say this, then they assume everything's better than it may really be. That's today's story. Tune in tomorrow for another.